Welcome to the Clinical Crash Course. I'm Dr. Collins. Today, we're deploying into the nephron for a masterclass on diuretics.
Listen up. Diuretics are high-yield tubular weapons, and we are hitting specific ion transporters.
Target 1, Acetazolamide, weapon of choice for altitude sickness, hits carbonic anhydrase in the proximal tubule.
Target 2, loop diuretics, high ceiling artillery. They take out the MCCQE transporter in the thick ascending limb. The rule is simple. Loops lose calcium.
Target 3, thiazides. They neutralize the NCC transporter in the distal tubule. They save calcium. Watch for collateral damage, Hyper-GLUC.
Final target, potassium-sparing agents, terminal engagement at the collecting duct, block ENaC or the aldosterone receptor. Let's go.
This content is for educational purposes only and is not medical advice. Consult official guidelines and a specialist. All right, now that the briefing is over, let's execute a deep dive on these nephron mechanisms. Sarah, you're up.
Let's start with acetazolamide. It seems counterintuitive. Why is a diuretic the first-line treatment for altitude sickness?
It's a brilliant physiologic maneuver, doctor. Acetazolamide blocks carbonic anhydrase in the proximal tubule. This forces the excretion of bicarbonate, which induces a mild metabolic acidosis. The brain senses this pH shift and compensates by increasing the respiratory drive. The resulting hyperventilation boosts oxygenation and directly counteracts the hypoxia of high altitude. It's not about the water, it's about the acid.
Exactly. Now let's talk about the heavy hitters, the high-ceiling diuretics. They target the MCCQE transporter. Sarah, explain why the calcium rule is so absolutely vital for the boards.
Because it's a critical point of divergence with massive clinical implications. Loops lose calcium. By knocking out MCCQE, they disrupt the electrical gradient needed for calcium reabsorption. This makes them our go-to weapon for emergency hypercalcemia. Thiazides do the exact opposite. They save calcium, which is why they're a smart choice for a patient with both hypertension and osteoporosis. Two different targets, two completely opposite effects on calcium.
An excellent distinction. Now with thiazides, there's a constellation of side effects that is an absolute favorite for examiners. What's the most high-yield mnemonic?
Hyper-GLUC. It's burned into my memory. G for hyperglycemia, which can worsen diabetes control. L for hyperlipidemia, U for hyperuricemia, which can precipitate a painful gout attack, and C for the hypercalcemia we just discussed. You have to monitor these parameters.
Precisely. And that brings us to our final target, the collecting duct. Potassium-sparing agents like spironolactone are fantastic, especially in heart failure, because they block the aldosterone receptor. But their very name tells you the biggest risk, hyperkalemia. You absolutely must watch that potassium level.
So for our question of the day, let's focus on that U in hyperglycemic. Have you ever actually seen a patient develop a gout flare-up right after starting a thiazide? It's a classic textbook association, but we want to hear your real-world stories. Share them in the comments.
Okay, team, it's time to lock in this intel. Let's run the neural chat. Lock the tubular weapons. Acetazolamide. Altitude and acid.
Loops lose calcium, MCCQE. Thiazide, save calcium, NCC.
Hyper-GLUC is the side.
K-sparring, high K. Tubular weapons are locked and loaded, doctor. Altitude and acid. Loops lose calcium. Thiazide, save calcium with Hyper-GLUC on the side. And K-sparing means high K. Mastery complete.
Congratulations, you have mastered this module. If this content is valuable to you, subscribe to Clinical Crash Course. Now prepare for the next mission. We're moving on to M2, acid-base disorders. Dismissed.